Bismillah ar-Rahman ar-Rahim. This is Muhammad Abdul Ghani presenting on pressure recovery in aortic stenosis. When the blood flows through a stenotic aortic valve orifice, there is acceleration of blood from a low velocity in the LVOT into a maximum velocity at the level of the vena contracta. The cross-sectional area of the flow jet at the level of the vena contracta, which is the effective orifice area, is always smaller than the anatomical orifice area. The ratio of the effective orifice area to the geometrical or anatomical orifice area is known as the contraction coefficient. When blood flows through a stenotic aortic valve orifice, a portion of its potential energy, which is pressure, is converted into a kinetic energy, which is velocity, so that blood flow accelerates, and this is associated with a drop in pressure. Beyond the aortic valve, beyond the vena contracta and the effective orifice area, the flow jet re-expands and decelerates. And as total energy must remain constant, kinetic energy is converted back into potential energy. So velocity is returned back to pressure. However, part of the kinetic energy is irreversibly lost as heat because of flow turbulence. And this is because the jet suddenly expands. This is called the pressure loss. So the remaining part of the kinetic energy, or the remaining part of the velocity, is reconverted back to potential energy or into pressure, and this is called pressure recovery. So pressure recovery is a normal phenomenon. It shouldn't be a problem. The problem is that pressure recovery is often incomplete due to the phenomenon of pressure loss. So let's get practical. The extent of pressure recovery depends on the relationship between the size of the valvular orifice and the size of the aorta. The smaller the valvular orifice relative to the size of the aorta, the more flow turbulence occurs. And this leads to more inefficiency of pressure recovery. The extent of pressure loss generally becomes clinically relevant only in patients with smaller aorta, defined as aortic diameter at the sinotubular junction of 30 millimeters or less. So what are the implications of this? Doppler echo derives pressure gradient from velocity measured at the level of the vena contracta. Invasive measurements, on the other hand, are usually obtained a few centimeters beyond the valve when the pressure has already recovered. Therefore, the invasive pressure gradient, which corresponds to the recovered or the net pressure gradient, is generally lower than the Doppler pressure gradient, which corresponds to the maximum pressure gradient estimated from the velocity measured at the level of the vena contracta. In other words, Doppler pressure gradient tends to overestimate the severity of the aortic stenosis. So how do we account for this difference between the measurements? How do we account for the difference which is caused by pressure loss? One of the methods is to apply the energy loss coefficient formula, which equals the effective orifice area multiplied by the aortic area at the sinotubular junction divided by their difference. The energy loss index is another version which also accounts for the body surface area of the patient. So in conclusion, pressure loss leads to overestimation of pressure gradient and to underestimation of the effective orifice area by echo Doppler. It's never working in the opposite direction. It never leads to underestimation by Doppler. It should be suspected when the pressure gradient is out of proportion to valvular pathology and to the extent of LV remodeling in a patient with a small aorta. When we suspect this phenomenon, we can either apply the energy loss coefficient formula or we use invasive measurement of the pressure gradient instead. Thank you very much for your attention.